My second guest is Dr. Linda Venner. Dr. Venner is an internal medicine physician and Assistant Chief Medical Officer with Intermountain Health. She is the president of the Utah chapter of the Society of Hospital Medicine and has been practicing medicine for over 25 years. I'm here today with Linda Venner, an internal medicine doctor, to discuss the physical aspects of eating disorders.
Hi, thank you for inviting me to speak with you.
Great, let's just jump into it. Is there a specific medical criteria that one has to meet to be diagnosed with an eating disorder?
There are formal criteria for the various types of eating disorders, but what I would say is that eating disorders are a spectrum of behavioral concerns characterized by severe and persistent disturbance in eating behaviors and associated distressing thoughts and emotions.
What are some immediate consequences of malnutrition?
Really, immediately we all experience some malnutrition throughout the day, even with prolonged fasting. But immediate consequences would include mood regulation, energy, concentration, and sleep disturbances.
What about in the long term?
So, long-term malnutrition from eating disordered behaviors can include organ and metabolic dysregulation due to inadequate nutrients. These can include skin and hair changes, loss of bone density, which can result in an increased risk of getting fractures, immune suppression, cognitive function, and ability to think rationally, even about the eating disorder. And most seriously, arrhythmia, which could result in death.
And arrhythmia, that is?
It's a fatal heart rhythm that impairs the ability of the heart to contract and relax normally, moving blood around the body, which is, in effect, circulatory collapse.
I think that's a really scary and important concept to grasp, that eating disorders have serious consequences long term, and I think it really highlights the importance of seeking care as soon as possible, at any stage, in preventing this, because it's, a terrifying idea that even if you get help, you may have already caused consequences down the road for yourself.
Yes, very true.
What is refeeding syndrome in eating disorders?
So, when you're malnourished, you have severe electrolyte depletion that can result. And then when you're introducing nutrition back, which include carbohydrates, the body switches back into a carbohydrate metabolism, and the micronutrients needed for that, including potassium, magnesium, and phosphorus, are actually shifted into the cells as part of that cellular metabolism. And this creates a deficiency in our larger areas of cell tissue and vascular beds, which can lead to muscle cramping, seizures, and coma, and again, fatal heart arrhythmias.
I think that's a really great overview and something that's important for people to understand, because I think the term refeeding syndrome can be very vague and scary. So it's great to kind of have a more specific overview of what that might look like. What medical tests would you recommend to someone suffering from a restrictive eating disorder?
So I think anyone who's been engaging in calorie-restricted eating, whether or not they have lost a significant amount of weight, but even if they've had a prolonged fasting period, really need to have blood pressure and pulse checks and basic laboratory tests, including electrolyte analysis, tests for thyroid function, tests for liver inflammation, which you can see in calorie-restricted eating, tests for muscle breakdown, and again, an EKG to look for dangerous heart rhythm patterns.
On the flip side to that, are there any medications that you recommend taking?
I think there are no medications that should be taken without an initial medical evaluation. I think a normal Intake of multivitamins is reasonable, but I wouldn't want that to replace the thought of normal eating of nutrients.
We've kind of talked about the long-term and short-term effects of eating disorders, but are there any warning signs that one should seek urgent emergency medical care?
I think if someone has a known eating disorder, is it a low weight or has had prolonged fasting, if they develop a fever or if they develop a respiratory illness or also any nausea, vomiting, or diarrhea, their bodies in their malnourished state are less likely to be able to handle those medical kind of illnesses. It could become a crisis. So I think really anyone who has significant weight loss, especially, or prolonged fasting, should seek medical care with fevers, with nausea, vomiting, or with shortness of breath.
Back to refeeding syndrome, do you think that should be a concern monitored by a team of physicians at any time?
Yes, absolutely. It is a risk, and the biggest risk, again, has to do with the severity of the electrolyte depletion, the rate of the refeeding, and the current electrolyte state, which you may or may not know if you haven't tested laboratory values. So yes, if there are any significant electrolyte deficiencies and you're introducing food back to someone who has been malnourished, they should have that done in a monitored setting.
Once the recovery process starts, what's the best way to track health progress in that?
I would say that having contact with a dedicated team, which would include a psychologist, a nutritionist, and a medical doctor, I think will help individuals with eating disorder behaviors as they engage to learn ways and strategies to cope with eating disordered thoughts and feelings and make progress to return to normal eating behaviors. Relapse is stressful, but can be a normal part of the process and can allow the person to develop new insights and strategies. And you really need to have a dedicated team of professionals who can sort of objectively and independently help the individual as they're moving through the steps of recovery.
How does disordered eating affect basic bodily functions like sleep? I mean, I think it's obvious that it affects so many different things, even immediately from malnutrition.
Yeah, actually, people with eating disordered behaviors frequently describe disruptions in sleep. They also describe a lot of GI complaints, bloating, constipation, heartburn. Also, dysuria and frequent urination can be seen and is thought, in women especially, is thought to be related to decreased estrogen production as the body sees a malnourished state.
I think eating disorders are so interesting and unique, especially in comparison to other mental illnesses, because there are so many physical problems that are caused by them, and it's almost a self-perpetuating cycle, because as these physical problems are occurring, I mean, it can cause decreased well-being mentally as well. How do eating disorders affect mood and concentration?
Yeah, I think initially for someone with a restrictive eating disorder, that actually restricting eating causes them decreases their level of anxiety, and that's why it's self-perpetuating. But over time, it certainly impairs their ability for really normal kind of frontal lobe cognition and other higher brain functions, and can really result in that person not being able to be the best judge of how their eating disorder is affecting them.
I've learned from my own research that the brain itself is 60% fat. So when you are starving the body, it needs to burn fat and whatever you have for fuel. So you're literally starving your brain as you starve your body, and it's not able to function at the level that it was before. Do you have any thoughts on how one's physical health can affect their mental health?
Well, I mean, I think we see a lot of examples of that. I mean, people with chronic pain, for example, right, tend to at some point develop pretty severe mood disorders, which is very understandable. I think people with eating disordered behaviors, again, they don't have their normal brain function, which gives them sort of that resiliency and that elasticity of thinking, and as well as just the disordered eating behavior cycle can be so all-consuming that it actually is causing a lot of social isolation in the individual as they're really focusing on the eating disordered behaviors. So I think it as their eating disorder is, those eating disorder behaviors are driving them to social isolation, they're more likely to have worsened depression and anxiety. And then I think because the brain is starved of critical nutrients and fat, that they are just not able to sort of regulate mood, regulate body temperature, and again, those higher frontal lobe cognitive functions are just not happening as they were when they were well nourished. Not well nourished, but when they were well nourished.
That's so interesting that the eating disorder itself, I mean, thrives on isolation and does what it has to do to keep itself going no matter what. Are there significant biological differences between males and females relevant to the physical aspect of recovery?
Yeah, I would say definitely. There's emerging research that suggests that there's sex-based differences in brain structure and function related to how we process rewards, our impulse control, and emotional regulation. And these not only affect eating disorders onset, but they can certainly affect the recovery trajectory. Additionally, males and females with eating disorders struggle with emotional regulation. They both do, but males show a different profile of emotional difficulties, like externalizing behaviors or difficulty identifying emotions. So they get into more maybe legal trouble or substance abuse trouble.
I'm glad you touched on the emotional aspect of that, because I know that males have a greater body mass in general and therefore need more calories, but it's interesting how that presents in the disorders themselves and kind of how those sector off in body image. If a patient has concerns about the development of an eating disorder and is seeking physician care support, who should they direct their concerns to?
Well, so any point of contact where a patient contacts medical care for any condition, it is really the obligation of that health system that they're contacting to route them to resources. I think that doesn't always happen as much as we would want it to, but that really should be the goal, is that wherever someone concerned about an eating disorder is first being assessed, be at a primary care office or an urgent care or emergency department or behavioral health clinic, or if they're at a specialty visit for something like dermatology and mention it to their doctor. Really, it is sort of the obligation of that person to help design a next step for them. But really, I would say that the first step is really for a medical doctor to assess for unstable medical situations, right, and treat any emergent critical situations, and also to help to connect to a behavioral health provider.
I'm glad that there's a standard for that in addressing the physical aspects of things, because I think sometimes it can feel like playing referral telephone in a way when you're seeking answers, and efficiency and speed can be so important in the treatment of eating disorders. So it's good that the concerns are being met that could cause immediate harm. I think it can also be really intimidating to start a treatment program because patients don't really know what to expect. So what's the difference between maybe an inpatient or a partial hospitalization or an intensive outpatient program?
So I would say that those program levels are designed to sort of meet the patient where they are at in terms of their medical stability. For patients who are really medically not stable, either because of a very low body mass, because of unstable vital signs, or unstable electrolytes or kidney function, or any liver dysfunction, that those patients need to be monitored in an inpatient setting. I think if patients do not have an actively unstable medical issue that needs to be addressed, that but they are meeting very concerning parameters, probably particularly with a very low body weight, that they could be monitored in a partial hospitalization program where they're seen every day in a structured setting and have vital signs and labs and EKGs checked. And then I think once patients have demonstrated that they are remaining medically stable, then they could move to an intensive outpatient program.
That's a really good overview. Do you think eating disorders are issues of public health and can be addressed as such, or are they individual concerns?
I think a lot of things can span the public health realm. So let's define that first. So public health is concerned with prevalence and impact of a disease, mortality, morbidity, treatment costs, loss of productivity. So to break those down a little bit more, with eating disorders, prevalence and impact of a disease is increasing with eating disorders. And then in terms of mortality for the behavioral health conditions, eating disorders have one of the highest mortality rates. From a morbidity standpoint, eating disorders co-occur with depression, anxiety, sometimes with substance abuse, and all of those things together increase the burden on the health and healthcare systems. And you can calculate measurements such as disability adjusted life years and quality adjusted life years, which really, from a empathetic standpoint, really mean how is this individual doing at reaching their own life goals. But I think from a more pragmatic society standpoint, you have to say how much less productive are these individuals in contributing to things like the economy because of their disease, and is it worthwhile to put resources towards getting them better. So things, of course, too, like treatment costs are always looked at, and treatment costs are higher if you do not have successful programs because you tend to have a lot of risk of readmission. So that's how public health is really defined. It is addressed in the public government space, and the levers to address any public health diseases are really policy reform, education and prevention programs, accessible treatment programs, and research. But again, that funding needs to come from the public space.
Well, mental illness is so stigmatized. People are afraid to speak out or seek help for fear of being judged or stigmatized. As you're a medical doctor yourself, I wanted to share this kind of interesting study with you. It conducted in 2022 by York University that said that out of 21,000 medical students belonging to 20 different countries, this review demonstrated that 17.35% of medical students screened positive for feeding and eating disorder symptoms, and that this number is expected to continue increasing, and that's compared to 9% in the general public. And obviously, medical school is extremely challenging, but I think it gives perspective that a lot of people who struggle with disordered eating and mental illness are highly successful and motivated people. How do you walk the line between professionalism and empathy with your patients? I kind of wanted to end on a personal question.
Thanks. That's actually a really thoughtful question. Taking care of patients with eating disorders can be incredibly challenging because they are downplaying their symptoms or misrepresenting their eating, and it's likely because they are unaware of the severity of their eating disorders. What it can feel like as a provider is that they're actually attempting to manipulate your response in order to get you not to impose treatments on them that they don't want. So I think the most important thing is to develop a trusting relationship where you can impart some data, measurements to create maybe some guardrails just to address really critical illness, but then just kind of bridge the person with the eating disorder to a multidisciplinary team that can help them. But in a single encounter, if you're a hospital-based physician, it can be a very difficult dynamic.
Well, thank you so much for your time. That was so informative.
Thank you.